I think the data that have been published thus far suggests it is a highly efficacious agent for B-ALL. I think equally important is it's an incredibly well-tolerated agent to incorporate into our therapy. We know that it is highly efficacious in our relapse populations, but I think important not to save our most effective agents for the relapse setting. So we need to study how best to incorporate Blinatumomab and other immunotherapies into the management of our upfront patients with the goal of preventing relapse rather than using them after a patient has already relapsed. So in 1731, we're studying if the inclusion of blocks of Blinatumomab intercalated with our standard chemotherapy can improve outcomes and prevent relapses, particularly in patients with high-risk disease features, so unfavorable cytogenetic subgroups that we know tend to be chemo-refractory, and then groups with persistent minimal residual disease where we know that's been demonstrated to be efficacious in the adult setting. We haven't yet fully investigated the use of Blinatumomab in this setting in pediatric patients, so we're really excited. That's about a 5-year study that we anticipate. And we're a couple of years in. We've enrolled over 2,500 patients thus far, and are going to look to get to around 6,000 patients. So a lot of pediatric setting of how to use Blinatumomab, in our pediatric patients when they're newly diagnosed. Another children's oncology group study is sort of tackling one of the ways in which we know patients can be resistant to Blinatumomab and other immunotherapies, and that's through basically T-cell exhaustion or dysfunction. And so to enhance the efficacy of Blinatumomab by boosting the function of the T cells through the use of PD-1 blocking agents, in this case, Nivolumab. So that's an exciting sort of future direction, I think, ways in which we can enhance the efficacy of Blinatumomab in our patient populations. I think there are other studies that hint at places where Blinatumomab in particular at our patients. A particular subset in which we in pediatrics really struggle with are our Down syndrome patients. Patients with Down syndrome are 20-fold more likely to develop acute leukemia in their lifetime compared to those without Down syndrome. When patients with Down syndrome develop acute lymphoblastic leukemia, these patients tend to do worse than patients without Down syndrome. And that's probably because the biology of Down syndrome B-ALL differs. They're less likely to have favorable cytogenetic lesions. But moreover, those patients really don't tolerate our intensive chemotherapies well at all. They really suffer from extreme toxicity chemotherapies, including high rates of infectious toxicity and even death. So one of the aims of AAL 1731 is also to incorporate Blinatumomab for this particular challenging subset of patients. And in this case, we're swapping out 3 cycles of Blinatumomab for some of the more intensive phases of therapy. So we think that's another sort of role for Blinatumomab on the horizon. There are also studies that have investigated in another challenging subset of patients are infants with B lymphoblastic leukemia. These kids are really hard to treat and have been largely refractory to most of the therapies we've tried for them to date. There's at least a case series of patients that have had great success with Blinatumomab. And then, of course, there was a really exciting paper from an adult group published in the New England Journal of Medicine last year that showed the combination of steroids, tyrosine kinase inhibition, and Blinatumomab might be a chemo-free cure for patients with Philadelphia chromosome positive B-cell ALL. So I think all those sort of hint at where we might Blinatumomab in the future, a source, of course, really built on a strong foundation showing its efficacy in a number of different clinical scenarios.